Hello, today we'll be talking about Chapter 16, Outcome Identification and Planning. And after reviewing this chapter, the things that you should be able to do is describe the purpose and benefits of outcome identification and planning, identify 3 elements of the comprehensive planning, prioritize patient health problems and nursing responses, describe how patient goals, expected outcomes, and nursing orders are derived from the nursing diagnosis, develop a nursing care plan with properly constructed outcomes and related nursing interventions, be able to differentiate nurse-initiated interventions from physician-initiated interventions and collaborative interventions, use the criteria to evaluate planning skills, be able to describe 5 common problems related to planning and their possible causes and remedies, and describe the rationale for standardized outcomes and nursing interventions for nursing. So as the nurse, you'll be collecting and interpreting data, identifying patient strengths, health problems, and then you have to plan your nursing actions. During the outcome identification and planning step of the nursing process, you will work in partnership with the patient and the family. And part of your job will be to establish priorities, identify and write expected patient outcomes, select evidence-based nursing interventions, and then communicate the nursing care plan. During this process, you'll be using different things, such as a goal. What is a goal? A goal is an aim or an end. A patient outcome. This is an expected conclusion to a patient's health problem or a well diagnosis expected conclusion to the patient's health problem. The words goal, objective, and outcome are often used interchangeably. In some practice settings, goal or objective is used to describe what is wanted, and outcome is used to describe the results achieved. In nursing, the phrase expected outcomes is used to refer to more specific, measurable criteria used to evaluate the extent to which a goal has been met. So you'll see this when we use the nursing care plan. We have expected goals that have to be specific and measurable. And then at the end of that care plan, we're going to evaluate those goals to see if the patient was able to meet them or if we need to tweak them a little bit. Also, the goals have to be something of interest to the patient, because if the patient has no interest, then they'll have no desire to achieve that goal. During this time, the nurse, the patient, and the family have to work together as much as possible. And again, this is the outcome identification and planning stage, because if the outcomes in the care plan are not valued by the patient or don't contribute to the prevention or resolution of the problem or reducing the patient's problem in some way, the care plan might not work. So this is a critical skill that you have to learn as a nurse, and it will help you successfully intervene with the patients. Now, a formal care plan will allow the nurse to individualize care to maximize the patient's outcome achievement. They'll set priorities. They'll facilitate communication between the nursing personnel and their coworkers or colleagues. They help promote continuity of care and high quality, cost effective care. It can help us coordinate care. We evaluate the patient's response to the nursing care. We can create a record that can be used for evaluation, research, reimbursement, and legal purposes, and it helps promote nurses' professional development. Now, it sounds kind of complicated when we say we're going to put all this into a nursing care plan, but you actually engage in this informal planning during practice all the time. This is the link that we have between when we identify a patient's strength or a problem, and then we provide a nursing response to that problem. So maybe you're working on a surgical unit and a post-op patient is complaining of incisional pain. So you're going to change your priorities up for a second to provide time for yourself to go and figure out what's going on with the patient, assess the patient, determine what nursing measures you need to put in place to help reduce this patient's discomfort. So right there, you have formed a plan. So on this slide, when we talk about the law is your State Nurse Practice Act, as it outlines the scope of the nursing practice. Your State Board of Nursing also outlines what you are allowed to do or not to do. National practice standards, such as those of the American Nurses Association, also provide guidelines. Specialty professional organizations such as the American Nurses Association of Critical Care Nurses or Emergency Nurses Association help develop standards for certain specialty practices. The Joint Commission is a powerful accrediting body that has developed detailed standards that must be followed to keep accreditation. And again, the Joint Commission doesn't accreditate every facility out there. There are different commissions that accreditate different types of care out there. Like I work for the DDD, we don't fall under the Joint Commission, but we certainly fall under some other accreditors. The Agency for Healthcare Research and Quality, this organization develops, reviews, and updates clinical guidance aid to aid healthcare providers to prevent, diagnose, and manage clinical conditions. And then your employer, because each facility usually develops a unique set of standards, cares, guidelines, policies, procedures, critical pathways, and so forth that reflect how nursing care should be given in specific situations. Say a formal plan of care allows the nurse to individualize care that maximizes outcome achievement. It allows us to set priorities. We can communicate between nursing personnel and our colleagues. We promote continuity of high quality, cost effective care. It helps us coordinate care, evaluate the patient's response. It also helps us establish a record that we can use for evaluation, research, reimbursement, and legal reasons. And it promotes our own personal development. So as we're doing this outcome identification and this planning of care and this clinical reasoning for this patient, we also have to be familiar with standards and agency policies for setting the priorities, identifying and recording expected patient outcomes, selecting evidence-based nursing care interventions, and recording of the care plan. We also have to remember that the goal of patient-centered care is to keep the patient and the patient's interests, preferences central in every aspect of planning. Because without the patient or their input or their value as part of the program, it's not going to work. We have to keep the big picture in focus. What are the discharge goals for this patient, and how should this direct each shift's intervention? We have to trust our clinical experience and judgment, but be willing to ask for help when the situation demands more than your qualifications and experience can provide. And it has to be valued and collaborative. We respect clinical intuitions, but before establishing priorities, identifying outcomes, and selecting nursing interventions, we have to be sure that research supports this plan. And also, we have to be able to recognize our own personal biases and keep an open mind. So typically in the acute care setting, we have three basic stages of planning: the initial, the ongoing, and the discharge phase. In some other settings, like long-term hospice care or a clinic, initial ongoing planning may be the primary types of planning. If you do develop a comprehensive care plan on the patient's first day, but you fail to update the plan, then the plan itself will not be effective or efficient. So failure to update that care plan as needed is a common problem in a lot of healthcare settings. So the initial planning is generally performed by the nurse with the admission history, nursing history, and the physical assessment. It addresses the problems listed in the prioritized nursing diagnosis, and it helps Identify appropriate patient goals that are related to nursing care. For this process, you can often use standardized nursing care plans. These are a set of prepared care plans that help identify the nursing diagnosis, outcome, and related nursing interventions that may be common to a specific population or a health population. Examples of standardized care plans are those care plans that you might find in the hospital already in place for you on a computer or in a textbook. Sometimes facilities have developed plans or maps or critical pathways that they might even follow. This allows the nurse time to um, place towards making that plan individualized. So if you had to sit and write the whole care plan, it could be really time consuming. But if you have this standardized plan of care, then you can use those basic guidelines and just tweak them so that it individualizes it for the patient. The ongoing planning by any nurse who interacts with the patient. We keep the plan up to date, we manage risk factors, and we help promote the function of the patient. Remember, when the patient's in the hospital, one of our goals is to try to get the patient back to their previous level of functioning prior to admission. The ongoing planning helps us to make those diagnoses a little more clear. It helps us develop new diagnoses. It really helps us individualize that plan even more and make it more unique to the patient. It helps make outcomes more realistic and develops new outcomes and identifies nursing interventions to achieve those patient goals. And then the discharge planning is going to be usually by the nurse who worked closest with the patient. It begins when the patient is admitted for treatment. It uses teaching and counseling skills effectively to ensure home care behaviors are performed competently. And then remember, you can always reach out to another coworker or a social worker who might have strong resources in that area where the patient resides in order to make these goals more realistically achievable. Prioritizing nursing diagnoses. To prioritize nursing diagnoses, we first have to establish our priorities. So we develop a list of nursing diagnoses and then we rank them as high, medium, or low priority. High priority nursing diagnoses pose the greatest threat to the patient's health and well-being and may even threaten life. Diagnoses that are not life-threatening are ranked as medium priorities. And so these are those non-threatening diagnoses. Diagnoses that are not specifically related to the current level of health or well-being are of low priority. In all levels, the psychosocial needs have to be considered as well as the physiological needs. So we will work with an interdisciplinary team to set priorities for nursing care that take account of all the patient's healthcare needs as recorded on the general problem list. And then we look at all the problems to determine the relationship among the problems, like what's causing or contributing to what. This makes sense to deal with medical or suspected medical problems first, because if we can resolve those, then it will help eliminate a lot of the other human responses. So, for example, the nurse sees classic signs and symptoms of appendicitis and tries to identify and manage a nursing diagnosis of pain without first consulting the physician or nurse practitioner. What could happen? Well, the appendix may rupture before you get to develop that plan of care to relieve the pain. And then now we have a much more critical situation here. So you can use helpful guidelines to help facilitate clinical reasoning and prioritizing patient problems by using Maslow's hierarchy of human needs, patient's preference, and anticipation of future problems. So, for example, Maslow's hierarchy of human needs, because basic needs have to be met first before a person can focus on a higher one. Patient needs may need to be prioritized according to the following hierarchy. So we're meeting those physiological needs first. So those physiological needs, those needs for oxygen, food, water, temperature, elimination, sexuality, activity, and rest, these needs have the highest priority and are essential for survival. Safety and security needs. The person's need to be protected from actual or potential harm or to have freedom from fear. Love and belonging needs. Understanding and acceptance of others and giving and receiving love. Self-esteem needs. Needs to feel good about oneself and believe others hold one in high regard. And self-actualization needs, the highest level on the hierarchy of needs, which includes the needs for individuals to reach their full potential through development of their unique capabilities. So which nursing diagnosis would most likely be considered a high priority? Answer B, impaired gas exchange. Impaired gas exchange poses a threat to the patient's well-being. And remember, I said that the high priority diagnosis is going to pose a threat to the patient's well-being. A medium priority diagnosis would be non-life threatening, and low priority would not necessarily be related to the patient's current health status. So those things you would want to remember. And you would want to think about that. So if I asked you on your care plan, about your patient in renal failure, what is your patient's highest priority here for well-being? You would want to think about one of those things that falls into that Maslow's number one category. Okay, that physiological um, number one category there. All right, and we're going to talk about that again in a second. Activity intolerance is a low priority because it's not specifically related to the current health problem, and so we did discuss that part. So again, one way that we can determine our patient's priority needs is to look at this Maslow's hierarchy of human needs and really understand it. So you want to remember that physiological needs have the highest priority. Okay, these are the needs that are essential for survival. So we have to have oxygen, we have to have food, we have to have water. Our body temperature has to be within the normal parameters. We have to be able to eliminate those wastes. Sexuality is also considered here, activity and rest. All these have the highest level of priority, and again, they are all essential for priority. How about safety and security needs? This is a person's need to be protected from actual or potential harm and to be free of fear. And then we have love and belonging needs. This is the understanding and acceptance of others in giving and receiving love. So we have to be able to feel that we're loved and give that love to others. Self-esteem needs. These are the needs to feel good about yourself and to believe in yourself and to hold yourself in high regard. Who are you as a person? Do you believe in yourself? And then self-actualization needs. These are the highest level of the hierarchy needs. And this includes the need for us to reach or fulfill our fullest potential. So when we're trying to better ourselves and make ourselves better, and we're developing these unique capabilities. So we think about clinical reasoning and establishing priorities. So, this also goes along with critical thinking, and we're investigating. So when you come to a problem, you know, you see this patient lying on the floor, and there might be 2 or 3 things going on with the patient. So maybe their respirations are, let's say, 10. And maybe they have a cut on their leg and they're bleeding. And maybe their skin is a little bit clammy and their fingernails are a little bit dusky. Okay? So you look at the patient and you have to, say to yourself, and, when you really have your knowledge base concrete, you have that experience from working in a certain place. You've practiced critical thinking and you've practiced doing scenarios. This can kind of come naturally to you a lot of times. So, you look at your patient and you say, what is happening with the patient? What do I have to address right away? So, how do you decide that? Well, the way that Maslow's helps you decide that is because you say, okay, 3 things I could see right off the bat, right? They have a breathing problem. They have a circulation problem, right? If I go to put to evaluate further, I might see something else that could lead to an airway problem. So, clinical reasoning, this is the thought process that uses thinking and strategies, and it helps us gather and analyze the patient's information, evaluate the importance of that information, and then decide on a possible nursing action to make. And we're looking for an action that's going to improve the client's physiological and psychosocial outcome. So it requires that we integrate both critical thinking in the identification process that will and the most appropriate nursing intervention together that will help improve the patient's client condition. So we think about what problems need immediate attention and which ones can wait. So if my patient has an airway problem versus a bleeding problem, which one is more life-threatening? And what do you think? You tell me, which one's more life-threatening? Is my patient going to die from an airway obstruction first, or will they bleed out before they die from an airway obstruction? What problems are your responsibilities, and which ones should you refer to someone else? So is there an intervention here that you can do, or do you need to notify the physician? And sometimes it could be a little bit of both. So your patient's not breathing well, you might sit them up in bed to expand their lungs first and put some oxygen on them, and then at the same time, you're still going to send to get help from someone else. All right, which problems can be dealt with by using these standard plans of care or critical pathways? And that's where you have to know, like, what are independent nursing actions that I can take myself, or, do I need to refer to someone else? Which problems are not covered by protocols or standard plans, but they have to be addressed to ensure a safe hospital stay and a timely discharge. So, that might be things like hand washing, simple hand washing, right? Because if I don't wash my hands and use the proper PPE, so let's use the combination of that. So let's say I'm taking care of 2 patients and they're in side by side rooms, okay? And one of my patients has C. diff and the other one does not. So if I don't follow the proper protocols that I need to take care of my patient that has a C. diff, like hand washing and PPE, and I leave that room and go into the other patient's room and I end up giving them C. diff, well, they may not get out of the hospital in a routine, timely fashion now, because they might end up with a secondary infection, or what we call a nosocomial infection, while they're in the hospital because of something that I didn't do or I shouldn't have followed. So I might not necessarily see hand washing in a standardized plan of care, but I know that I have to wash my hands before I deal with my patient. So hopefully you understand that process. Now, you always want to think about critical thinking because this helps us differentiate statements of facts, judgments, and opinion. When we critically think, it requires the nurse to creatively use reflection and engage in analytical thinking, meaning you have to analyze stuff, look at one thing, compare it to another, think about what sort of scientific research backs this, and it just helps promote meaningful thinking and connections between research and practice. So we talked about, using Maslow's hierarchy to establish priorities in the nursing diagnosis, and we can also use that as part of our clinical reasoning. We see this all the time in the nursing field. What do I do first? So, one example of doing this is using the ABCs. So we look at the patient and we say, is the airway patient? And maybe we'll say to ourselves, hey, yeah, the airway's patent, the patient's breathing, it's fast, but it's manageable. The chest is rising and falling symmetrically. Their O2 sats are above 90%. So maybe there's something else that's going on with the patient that's causing their irregular breathing. Maybe they have a fever or something. Um, how about the circulation? Is that compromised in any way? How is the skin? Is it tenting, or does it have good elasticity? How about the mucous membranes? Are they dry? Are they moist? How's that cap refill? Is it within normal limits? Is it delayed? And how's that heart rate? Is it within normal limits, or is it increased in rate? How about the pulses? Are they present? Are they weak? Are they thready? Are they full? Are they bounding? So we're looking at all these different things, and we're looking for relationships. We're looking for clusters of data. Um, what's going on with the patient. So, have any changes in the patient's health status influenced the priority of the nursing diagnosis? So, the patient, the way they change on a minute to minute or day to day basis, those things could change. Have changes in the way the patient is responding to the health and illness or the care plan affected the nursing diagnosis? That can be realistically addressed. So, maybe the patient is getting good response to the antibiotic if they're on an antibiotic or something, and the health is improving, or maybe they're not responding at all. So, this is one of the reasons why we do cultures on patients before we start them on an antibiotic, so we can make sure that they are going to respond appropriately to the antibiotic. But we don't always get that 100% right. So the patient could be on the antibiotic and it could not be responding to the infection, and that could cause their health status to continue to deteriorate. Or we could even put the patient on an antibiotic that maybe their body couldn't tolerate, and so it caused them to have some sort of acute kidney injury or something along that line, and it affected the way that they responded to the illness or the actual antibiotic itself. So those are things that we may have to tweak or address. So when you're going through these care plans and you're developing, it could be a constant change based on the patient's response. And then, are there relationships among diagnoses that require one be worked on before another one can be resolved? So maybe your patient has a medical diagnosis that we have to fix. And we talked about that, I believe, on a previous slide, um, where your patient was having pain, and it was abdominal pain, and the patient had appendicitis, and so the nurse was focused on the actual pain, but in the process of focusing on the pain, she overlooked the fact that he could have appendicitis, and if the appendix ruptured, that's going to change the whole dynamic of the process. If we were able to correct that issue with the appendix and remove it, decrease the inflammation, take care of those things, then we also could probably resolve the issues with the pain. And then, and our patient doesn't die because their appendix exploded. Can several patient problems be dealt with together? Sometimes. Sometimes there's things that are going on, and if you correct it in one area, it helps correct it in multiple areas. Um, but not always. But there are some things that definitely could be dealt with together. So learning to write these outcomes is going to take practice. The outcomes are derived from problem statements of the nursing diagnosis. In your book, table 16.1, you can see some examples, one being pain. So pain is the problem statement of the nursing diagnosis, and then the outcome or the goal is within 8 hours the patient will report that pain is absent or diminished. And you can make those goals a little more specific just by saying, like, within 8 hours, the patient will report that the pain level is less than a 4. And that gives it a little bit more just specific and a measurable outcome. Other outcomes that may contribute to the resolution of the problem can be written as well. For example, imbalanced nutrition, more than body requirements. So, and then the outcome or goal would be within 2 weeks, the patient would reach a target weight of 122 pounds. And then you could actually put a date in there as well. Now, there is a project called the Nursing Outcome Classification, and it's a project that has comprehensive standardized language in it, and it's used to describe patient outcomes that are responsive to nursing interventions. It has about 490 outcomes with definitions, indicators, measurement scales, and supporting references, and it can be used for individualized family or community care plans. And then we also have the North American Nursing Diagnosis Association International Diagnoses and NOC, which also provide a comprehensive approach to care planning. So it also uses standardized language to ensure that it captures the things that you need to use in the care plan, and it will help you, guide you, and be able to write a better care plan. We also think about outcomes in two different terms. So outcomes can either be long-term or short-term. For long-term goals, of course, they would require a longer period to achieve, usually more than a week. Short outcomes could be done within a few hours or a couple of days. Long outcomes can also be used as discharge goals. And then, you could determine your goals and your length of time in which you want it to complete. They could also be more broad or written as a way to be communicated to the entire nursing team as an end result of nursing care for a particular patient. So an example of that would be women on a nursing unit that are stop. Okay, at least one outcome per nursing diagnosis should directly resolve the problem statement in the nursing diagnosis. There's also a project called Nursing Outcome Classifications, and this project presents a comprehensive standardized language that you can use to describe patient outcomes that are responsive to nursing interventions. It lists about 490 outcomes with definitions, indicators, measurement scales, and supporting references, and you can use these outcomes when developing an individualized care plan or even when developing one for a family or a community. There are also linkages between the NANDA, or the North American Nursing Diagnosis Association International Diagnoses, and the NOC, the Nursing Outcome Classification. And these help facilitate a comprehensive approach to care planning. So when you use standardized language, it helps to adequately capture the uniqueness of the patient or the family. Also, our outcomes can be long-term or short-term. Okay, long-term would require a longer period, usually more than a week. They also can be used as discharge goals, in which they're more broadly written, and they'll communicate information to the entire nursing team as to what your end results you might want to see for the nursing care of a particular patient. So an example of a broad long-term goal would be like if we had a patient that we discharge home after a hip surgery, and we would want that patient to return to the long-term care facility pain-free, with the incision site healed and the leg in good alignment. An example of a broad-term, short-term outcome would be like we observed a patient status post surgery for the hip, and the patient reports that comfort measures and medication are satisfactorily managing that pain. And then we talk about categories of outcomes, such as cognitive. So cognitive, that talks about the patient's knowledge. So an example of this would be we've taught a patient how to describe the benefits about applying moist compresses to a leg ulcer after discharge, and this patient is able to verbalize back to us within 1 day of that teaching those same benefits of applying those moist compresses that we described to them. A psychomotor would be the patient's achievement of a new skill. So this would be actually the patient applying those moist compresses to the leg and being able to demonstrate that they're able to apply those moist compresses correctly. Affective describes changes in the patient's values or beliefs and attitudes. So getting the patient to understand that things that they are doing are affecting their health, and maybe the diet they're eating needs to be changed, or understanding that if they don't follow certain regimens, it could cause them to get more infections. So, just teaching a patient and having them believe and having an attitude that what they're doing is valuable for them. Because if they don't feel that everything that they're doing is valuable towards them, they're probably not going to be cooperative, and your plan isn't going to be as effective. And then physiologic. And an example of physiologic would be like, let's say you discharged a new baby home, and you would want the baby, to demonstrate once it was discharged home that it had adequate weight gain, that the sleep and wake patterns are within normal limits, that the baby is comfortable, which would indicate that, the parent is doing a good job. So those are things that would be physiological outcomes. So, with the baby, like, there's a certain percentage of weight gain that we would expect that child, or weight loss, that we would expect it to not be above. Okay, so, you send a newborn home, of course, they're going to have a little bit of weight loss in the first couple of days, but you wouldn't want it to be more than like 7 to 10%. So those are the kind of things that would be physiologic. So which outcome would be considered an effective outcome? Remember, effective talks about values, beliefs. By 6-9-19, the patient will correctly demonstrate the procedure for washing her newborn baby. By 6-9-19, the patient will list 3 benefits of eating a healthy diet. By 6-9-19, the patient will use a walker to ambulate the hallway. By 6-9-19, the patient will verbalize valuing his health enough to stop smoking. So again, we're looking for an effective outcome. Which one would be an effective outcome? So hopefully you chose D. By 6-9-19, the patient will verbalize valuing health enough to stop smoking, because an effective outcome describes changes in patients' values, beliefs, or attitudes. So if the patient believes that the stopping of the smoking is going to benefit his health and he stops that smoking, that's an effective change or outcome. Now, when we think about clinical, functional, and quality of life outcomes, we think about types of outcomes um, that would describe the expected status of the health issues, or describe the person's ability to function, or focus on key factors that affects someone's ability to enjoy life. So our clinical outcomes, those are the ones that will describe the expected status of the health issue at a certain point in time, like after the treatment is complete. And they help us address whether the problems are resolved or to what degree they are improved. For our functional outcomes, they describe the person's ability to function in relation to the desired usual outcomes. So how am I functioning now in regards to what my desired usual activity is? And then the quality of life, which again focuses on key factors that affect somebody's ability to enjoy life and achieve those personal goals. So some other considerations that you want to think about is you want to make sure that your outcome is culturally appropriate. Okay, what might be an appropriate intervention for one person might not necessarily be one for someone else. So chapter 5 will discuss that a little bit better for you about culturally appropriate care. So I would definitely go back and review that. All right. And then we always have to remember that we nurse people, not problems. So every outcome you write has to support the overall treatment plan and make sense in terms of the overall goals for the patient. Okay. For example, if you have nutritional outcomes, they might be appropriate for a patient that's losing weight, but not for someone who's dying. Okay, so and it might even be incompatible with someone who's dying, because we want them to have a peaceful death with dignity, not be stressed out about nutrition. All right, and sometimes this is a big part of hospice, because sometimes families are in denial, like your patient is actively dying and we really have to go with their wishes, but yet the patient's family is putting pressure on you. They're not eating, they're not eating, they're not eating. Well, at some point, you know they stop having that appetite, they stop having that desire to eat. And so they've been diagnosed, yes, as a hospice patient, and we do know, in fact, that they're dying. And so it can be stressful if we're trying to push nutrition on them at a time in their life when they just aren't interested in eating or drinking at that point. Okay, so parts of a measurable outcome. So to be measurable, outcomes have to have the following things. So a subject, all right, and this is the patient or some part of the patient. A verb, which is an action that the patient's going to perform. Verbs that are helpful in writing these outcomes might include things like define, list, verbalize, explain, identify, demonstrate, apply, okay, and then a condition. The circumstance in or by which the outcome is to be achieved. So not every outcome specifies conditions. The performance criteria, which is the expected patient behavior or other manifestation that's described in the observable, measurable terms. The target time, okay, and that's when the patient is expected to be able to achieve the outcome. So that might be realistic date, an actual date, or some other statement indicating time like before discharge or after viewing the film or whenever observed. So here's a couple examples of properly constructed measurable outcomes. During the next 24-hour period, the patient's fluid intake will total at least 2,000 mLs. At the next visit, 12-23-20, the patient will correctly demonstrate relaxation techniques. So sometimes it helps to include special conditions when you write the outcome if the information is important for other nurses, because other nurses should be reading this. So before discharge, the patient will ambulate independently the length of the hallway and back using a Philadelphia collar to support cervical vertebrae. So if you think about the acronym SMART, okay, remember that the goals have to be specific, measurable, attainable, reasonable, and time-bound. The nursing interventions classification helps define nursing intervention as any treatment based on clinical judgment and knowledge that a nurse performs to enhance patient outcomes. The project further goes on to describe types of interventions, which include interventions that nurses do on behalf of patients, both independent and collaborative, interventions both direct and indirect. So the NIC interventions include physiologic, which may include things such as acid-base management, psychosocial, which may include things such as anxiety reduction. Interventions are also included for illness treatment, such as hyperglycemia management, illness prevention, such as fall prevention, and health promotion, such as exercise promotion. Most interventions are used with individuals, but some may be used for families and communities. Carpenito Moya describes how the major focus of intervention differs according to the type of nursing diagnosis or collaborative problem being addressed. For actual nursing diagnoses, the interventions seek to help reduce or eliminate contributing factors of the diagnosis, to help promote higher levels of wellness, and to help monitor and evaluate the patient's status. For risk nursing diagnoses, the interventions seek to help reduce or eliminate the risk factors, prevent the problem, or help monitor and evaluate the status. For possible nursing diagnoses, interventions seek to collect additional data, rule out or confirm the diagnosis. And for collaborative problems, interventions seek to monitor for changes in status, manage change with status with the nurse and physician prescribed interventions, and evaluate the response. Your challenge in the planning phase of the nursing process is to identify nursing interventions most likely to achieve the outcome. There are nurse-initiated interventions, physician-initiated interventions, and collaborative interventions. We'll talk about more those in a bit. And now we're going to talk a little bit about the nursing diagnosis itself. So the first part of the nursing diagnosis is the problem statement. And this identifies the unhealthy response and indicates what should change. It also will help us suggest patient goals and outcomes and expectations for changes. So an example would be risk for impaired skin integrity with the goal of intact skin. The second part of the nursing diagnosis is the etiology, and this identifies factors that cause or contribute the undesirable response and prevents desired change. So this suggests nursing interventions. An example would be related to immobility. So we have a risk for impaired skin integrity, which is our problem statement, and the etiology is the immobility. So it's related to the immobility. So our interventions will be focused on what caused us to be immobile, because if we can improve the mobility, then we can decrease our risk for the impaired skin integrity. So our interventions, again, are focused on mobility, ambulation, and positive range of motion. So common errors: expressing the patient outcome as a nursing intervention, using verbs that are not observable or measurable, including more than one patient behavior or manifestation in a short-term outcome, and writing vague outcomes. So after we write the patient outcome, we identify various nursing interventions to help the patient achieve those outcomes. We use the NIC and the NOC. So the NIC is Nursing Interventions Classification. This is the first comprehensive, validated list of nursing interventions that's applicable to all settings, and it can be used by nurses in multiple specialties. It greatly facilitates the work of identifying appropriate nursing interventions. And then there's a website, in your book that you can go to that will help you find that. There's a link on page 395 for that. And then the NOC, okay, we talked about a little bit earlier. And that is the nursing outcomes classification, which is that standardized classification of patient, family, and community outcomes. And we went through that in the previous slide. All right, the NIC provides over 12,000 evidence-based interventions. It's based on individual patient problems and goals. And it can help us facilitate formulation of appropriate outcomes and goals. It facilitates selection of appropriate nursing interventions and helps facilitate communication of nursing treatments to other nurses and providers. Now, according to the NIC, there are 6 factors that should be considered when you choose an intervention. And those factors are the desired patient outcome, characteristics of the nursing diagnosis, research base for intervention, the feasibility of doing the intervention, the acceptability to the patient, and the capability of the nurse. The effectiveness of the nurse is directly proportional to the nurse's knowledge and of varied nursing strategies. Consider the following different nursing care options identified by 3 nurses when they are asked to describe nursing care for a woman 2 days after a C-section who's complaining of pain in the incisional area. So nurse A, check to see what type of pain medication is ordered and give it if the time interval is sufficient. Nurse B, assess the quality of pain, use the time to communicate support by means of expression and squeeze of hand, administer analgesic if indicated, assess effectiveness of the analgesic ordered. And nurse C, assess the quality of pain, and explore the possibility of contributing factors and increased gas in the abdominal area, concerned about the newborn, herself, or other family members. Use empathetic listening to communicate support and encourage the mother to share concerns. Change the patient's position in bed. Offer a back rub. If appropriate, suggest activity that will distract attention from the pain. Give the prescribed medication for pain and observe its effect. When administering the medication, use the power of positive suggestion to enhance its effectiveness. This will start taking the pain away in about 10 minutes and help you relax. It is possible that the patient simply needs prescribed analgesic to achieve the outcome. Patient will report minimal to no pain at assessment every 2 hours. In that case, all 3 nurses would have been effective in meeting the patient's need for the nursing care. However, it's possible that the prescribed medication is not sufficient, or the pain is compounded by the mother's fears about caring for her newborn, or her worries that the baby will ruin her relationship with the husband. Therefore, Nurse C, whose knowledge level is more comprehensive, is likely to be most effective in resolving the patient's care. The varied options available to the nurse have to be considered, because the more variables, the more options that you have available, then the more effective your nursing response will be. Just like when you're learning in school, not everybody learns the same way, right? So some people learn more visual, some people learn by reading, some people learn by lectures. Well, your patient's pain, there may be other things that can help your patient. It might not necessarily be the narcotic. It could be the combination of the narcotic, the change of position, the distraction, the back rub, and if one of those things don't work, then maybe something else that you're doing in that area works. But it's having these different options, and also, again, we have to go back and think about what would be culturally acceptable to the patient as well. That could also affect the way your outcome goes. So types of nursing interventions are nurse initiated. This is an action that's performed by a nurse without a physician's order. So a nurse initiated intervention is an independent nursing action that's carried out by a nurse prescribed intervention written on the nursing care plan. And it can also be any other action that the nurse initiates without the direction or supervision of another healthcare professional, and that results from their assessment of patient needs. So this is actually an autonomous action that's based on a scientific rationale that a nurse executes to benefit the patient in a predictable way related to the nursing diagnosis and projected outcomes. So nursing intervention that are actions performed by the nurse to help monitor the patient's health status in response to treatment, reduce risks, resolve or prevent or manage a problem, promote independence with activities of daily living, promote optimum sense of physical, physiologic, and spiritual well-being, give patients information they need to make informed decisions, and be independent. They do not require a physician's order or other health member team order. Nurse-initiated interventions, like patient goals, are derived from the nurse diagnosis. For example, many factors may contribute to obesity, such as deficient nutritional knowledge, convenience of high-calorie fast foods, lifetime snacking habits, limited food budgets, and low self-esteem. The nurse working with a patient who wants to lose weight could attempt to deal with all these factors, but this approach would be inefficient. So when carefully developing nursing diagnosis identifies specific factors that contribute to the particular weight gain problem, nursing interventions can be selected to deal directly with these factors. So similarly, nursing interventions for a patient with diagnosis of imbalanced nutrition more than body requirements related to lifetime snacking habits and heavy reliance on high-calorie fast foods might include education about the fat content and the calories in fast foods, as well as exploration of ways that the patient could change eating habits to a more nutritionally balanced meals with fewer calories. So, of course, the nursing approach wouldn't be the same for every patient with a weight problem. So, that is the art of nursing, careful identification of specific nursing interventions that are needed by each patient, and it's individualized to that particular patient's needs. Physician-initiated interventions are initiated by a physician in response to a medical diagnosis and then carried out by the nurse in response to that physician's order. For example, the doctor examines a patient that came into the ER after a motor vehicle accident, and they ask you to administer a medication to relieve pain and then schedule the patient for x-rays or other diagnostic testing. The nurse who implements those interventions is implementing the physician-initiated intervention. Both the nurse and the physician are legally responsible for these interventions. Nurses are expected to be knowledgeable about how to execute the interventions safely and effectively. Nurses who question the appropriateness of physician-initiated interventions are legally responsible to seek clarification of the order with responsible parties. Nurses also carry out treatments initiated by other providers, such as pharmacists, respiratory therapists, or PAs, physician's assistants. These are considered collaborative interventions. For example, a nurse caring for a patient after a motor vehicle accident may eventually implement interventions written by the physical therapist, the occupational therapist, or some other member of the healthcare team. As previously discussed, actions performed by the nurse in these nurse-initiated interventions will help to monitor the patient's health status, reduce risks, resolve, prevent, or manage patient problems, facilitate independence or assistance with the patient's activity of daily living, and promote an optimum sense of physical, psychological, and spiritual well-being. So in order to standardize nursing care, there's different forms that have been taken on, and past approaches have included procedures, standards of care, algorithms, and clinical practice guidelines. And each one of these approaches is aimed at helping the nurse identify and select the appropriate intervention that produce optimal care, reduce legal risk, and lower healthcare costs at the same time. So a procedure is a set of action steps for performing a clinical activity or a task. A standard of care is a description of an acceptable level of patient care or professional practice. An algorithm provides a set of steps that approximates the decision processing of an expert clinician and is used to help make decisions. These clinical rules are embedded in a branching flow chart normally. And then clinical practice guidelines are a statement or a series of statements that help outline the appropriate practice for the clinical condition or the procedure. National guidelines, such as those published by the U.S. Agency for Healthcare Research and Quality and the Cochrane Library, are generally based on the latest most comprehensive scientific evidence available and expert analysis. They help provide standards for delivering and evaluating care for patients with the same diagnosis. They compare structured care methodologies. So the Omaha system is one of the oldest of the American Nurses Association, recognize standardized terminologies, and it describes and measures the impact of healthcare services. It was developed by the Visiting Nurses Association of Omaha to document and manage home care services. It's now widely used across the healthcare discipline and settings, and it has three different aspects. Those steps include problem, intervention, and outcome. The four intervention categories are health teaching, guidance, counseling, treatments and procedures, and case management and surveillance. A nurse designing the care plan might discover that more information is needed about the nature of the problems underlying the need for nursing or specific interventions. Consultation is a process where two or more people with degrees of experience and expertise discuss the problem and its solution, and often proves to be helpful. So nurses might consult with a nurse specialist or other members of the healthcare team, including the provider, nutritionists, social workers, therapists, pastoral caregivers, and ethicists. Consultations are a valuable means for nurses to expand their knowledge and repertoire of effective strategies. So in your care plan itself that you're preparing, you might want to take a look at those different things. Where could you refer your patient to when you're discharging? What other resources do you have available to you that might be able to help this patient once they're actually discharged home from the hospital? You should know your strength, your limitations, and your values when identifying the best interventions to address patient problems, and to value the perspectives and expertise of the healthcare team members. When you know how to consult and when to consult, it's essential, and it can actually increase the outcome to a more positive outcome for that patient. So remember that it's never too early to begin learning who your best resources are out there that you can refer your patients to. This way they can continue their care once they're actually discharged home to the home environment. So just remember that your nursing care plan is a written guide. It helps direct the efforts of the nursing team that works with the patient to meet their goals. It specifies nursing diagnoses, outcomes, associated nursing interventions, and well-written care plans offer benefits to the patient, the nurse, the unit, administration, and the profession as a whole. Primary nursing care plans ensure that the nursing team works efficiently to deliver holistic, goal-oriented, person-centered care to the patient.